Well, if you're paying attention, obviously the scene has changed, and the reason for that is because we had some problems with the audio and visual quality for the live talk. So now we're recording a little piece of this from San Francisco, and hopefully this will come out clear. So we're going to jump back in where we left off. And on the next slide, we have dysthymia, and beyond major depression are so-called minor depressions. The researcher at Kiskell has made a good point of saying these are not minor at all. They are, obviously dysthymia is a less intense version and it doesn't cause as much dysfunction, but if you look at especially the chronicity of this, low-grade chronic depressions that last many years, if not a lifetime, the toll it takes on a human life is extraordinary. So it's not just the individual who suffers, but also their performance at work and school and relationships and families suffer as well. So Kiskell, I think, is right on the money when he says that these are not, in a real sense, minor. But they clearly are less intense and less severe than major depressions. From the slide you can see that 5% of the population in the United States, lifetime prevalence rate for dysthymia. One issue is that the majority of these people eventually are going to also develop major depression. And when that's the case, it's oftentimes referred to as double depression. On the next slide, we're going to see something very interesting. For years, and clearly this is what I was taught when I was in graduate school, dysthymia was considered to be primarily a characterological problem, characterological depression or depressive personality, and there were various arguments in favor of that. But about 10 years ago, again, Kiskell, who's probably the lead researcher internationally looking at depression, especially minor depressions, found this data that you see on the slide, and that is, you can see that about a third of people that are treated with antidepressants who have dysthymia have a very good response, and another third have a good response, although not full remission. What this really suggests are a couple of things. One is it argues against the notion that everyone who has dysthymia is due to characterological kind of issues. The fact that a third of people with dysthymia have poor response or no response to antidepressants certainly suggests there may be many other causes for dysthymia. But I think this has been a problem that's happened a number of times in psychiatry, where you look at things from a superficial symptomatic perspective and kind of clump everything together and call it dysthymia or schizophrenia or what have you. But especially in light of this data from pharmacologic studies, it looks like, although there's a lot of symptomatic similarities, that there are some probably significant differences in terms of the underlying etiology and therefore treatment. The other point that I want to make, though, is that because dysthymia is difficult to treat, and because of the high response rates to antidepressants, then one can make a good case for when you diagnose someone with dysthymia is to offer them trial on medications. And if they have a very good response, then they may not need more extensive psychotherapy. The folks that respond well to antidepressant medications, I think we can assume, have a chronic, low-grade neurobiologic condition. And all conditions in medicine have degrees of severity, epilepsy and heart disease and so on and so forth. So it's not unreasonable to think that you may have more minor, albeit chronic versions of depression as well. The next one, has success of antidepressants been oversold? Patient selection criteria. Now this is an important point that I want to make in kind of discussing really the limitations of antidepressant medications. It has to do with FDA criteria, the things that they require for having a drug approved as an antidepressant. And if you've never heard about this before, this may blow your mind, but this is the absolute truth. When drugs are going to FDA for approval, these are sometimes called registration trials. They have to do at least 2 studies with adequate sample sizes to demonstrate that a drug is significantly more effective than placebo or no treatment. But what's interesting is the selection of subjects for these research studies. And what they do is they of course have to have people to have diagnosis of major depression, unipolar depression. It's very appropriate that they rule out any history of or signs or symptoms of bipolar disorder, quite a different disorder, and that people don't have psychotic symptoms. And all that's quite appropriate. But beyond that, these subjects that are chosen for these studies have the following exclusion criteria. One is they can have no access to disorder, no personality problems, that they need to have a very clean garden-variety, rarefied kind of depression, uncomplicated by personality disorder. No coexisting axis 2 disorders like substance abuse. No medical conditions that have sometimes been shown to be associated with causing depressive symptoms, and not taking any prescription medications that might cause depression. So the real question is, where do they find these people? In clinical practice, all of us know that people come to us with complex comorbidity. But in these studies, they have these folks that have very clean, uncomplicated depressions, and then they are treated and you have certain outcomes. And of course the big question is, can you then generalize those results to the general clinical population? And a lot of people, including myself, would say, I don't think so. This is an interesting study done a few years ago by Zimmerman, and what they did in this study is they took a look at 346 people that had major depression, okay? And they said, just for fun, let's use the same exclusion criteria on these patients. They would experience if they were going through a registration trial for FDA approval, and as you can see from the slide, 86% would have been excluded from the studies. So coming out the chute, right after a drug is approved by FDA and then starting to be used in the real clinical population, many people say it's just getting to first base to get FDA approval. The proof of the pudding really is in watching what happens in terms of treatment outcomes over a period of a year, because clearly we do treat people who have a lot more complex disorders. Now, if you take a look at the study outcomes in these registration trials, they typically, it varies a little bit from drug to drug, but they typically look like what you see on the slide. About 15% of people just can't take the drug. They can't tolerate it. They have side effect problems from that. And of course that's a failure. That's a drug failure because they can't take that. 35% have no response at all, despite adequate dosing and being on the drug long enough period of time. 50% generally are considered to be responders. And this is pretty much the case across the board with the different kinds of antidepressants. But we really need to look at this more carefully, okay? And by the way, this approach is called intent to treat. But if you take a really close look at these people that represent the 50% that respond, it's really important to note that not all responders are going to go to full remission. And this is a really big deal. Take a look at the slide. According to criteria established by the FDA, to be a responder means that you have to have either a 50% reduction in scores on standardized depression rating scales. The one that's used the most is the Hamilton depression rating scale, although there are others that can be used. So a 50% reduction, or reach the cutoff point for remission, which on the HAM-D is considered to be a score of 7 or less. Now, there are many people that may start off with a Hamilton score of, let's say, 30, and they are severely depressed, and if they have a 50% reduction in symptoms, on the one hand, that's good. I mean, it has had a very significant impact on reducing the severity of symptoms. However, with a HAM-D score of 15, people are not well. Okay, so got to keep in mind that 50% doesn't come anywhere close to representing, in many of these patients, full recovery from the depression. A closer look at this slide shows that of the responders, now that is the 50% that respond, half of them actually do meet criteria for remission. Half of them, but the other half are partial responders. Once again, they are experiencing symptomatic improvement, but they're not fully recovered. So this can be oftentimes very misleading when you look at this data. A study that was done more than 10 years ago, in the next slide, took a closer look at these people that actually met criteria for remission. They had a HAM-D score of 7 or less, but actually, in reality, only 18% of these people were completely symptom-free. It's not unusual that many people who ultimately had a very good response to antidepressants will have some residual symptoms, 82% in this case. Among those are things that you can quantify, like sleep disturbances actually continue to be a problem, but others are much more hard to quantify but are tremendously important, and that has to do with the quality of life. Many of these people who have full response will say, thank God, things are a lot better. I'm grateful for that. But you know, I don't feel like I used to. I just don't. Now, some people have argued that this may be just, the outer limits of the success of antidepressants. They can't result in a home run. They can get you to third base, maybe. That's certainly a real possibility. Another possibility is that there may be some brain damage that has occurred as a result of being exposed to months and months of depression. And of course, that can also be an issue as well. But is it good enough to have a partial response? Well, no, it isn't. Beyond the human issue here, ongoing suffering, even though it's less severe, the fact remains, as we see on the slide here, lots of people have partial recoveries, but stay stuck in a low-grade depression chronically. And the biggest problem here is those people that have some residual symptoms are significantly more likely to have recurrences. And if they have recurrences, they're more likely that the recurrences will occur sooner than later. Time to next episode, as you can see here, if it's among people that have recurrent depression, 3 times longer period of time to their next episode if they have full recovery versus people that have partial recovery. So they're going to have a likelihood of having recurrence much sooner.